and I would like to welcome Nurse Tanay to the network and let her tell you all about the amazing genomics of cancer. So I will introduce you, Mary, and let you start your presentation, if that is okay, please.
Right. Hi. Good afternoon, everyone. Thank you for coming to speak with me today. I'm Mary.tanay. I'm the Macmillan Nurse Consultant for Genomics here at the Berkshire Cancer Centre. So just to give you a bit of about my role. So this is a role that is specific into looking at how we can offer the service to do some genetic tests and genomic testing, specifically in cancer, different tumor sites and so forth. As you are aware, there's a lot of involvement and also a lot of improvement in genomic and genetic testing recently, and you must be hearing a lot about it on the news. So hopefully this session will answer some of your questions, and we also have some questions towards the end. So if there's anything that is unclear, please ask me. So I've basically done that. So this is Bitesize Genomics, Hereditary Cancers and Precision Medicine. So in this session, what we're going to talk about are, the first, we're going to define genomics and genetics. These are two words that you might be hearing very often now, but we're just going to define them and also understand what's the difference between the two. And then I will also be using a few examples so that we can explore the genomic tests and hereditary cancers that are being identified by using this testing, and also how genomics help advance cancer treatments and the benefits of genomics to individuals and healthcare. And I will also be using some examples that we are of the services that we are already using and doing here at Royal Berks. So going back, if we're going to understand genomics and genetics, it's important to understand the composition of our bodies. And to be able to explain this, I usually use the analogy of a library so that we can think about what are the cells, genes, and DNA, and how do they make up the whole body. So if we think that the library is the entire body, then the books will be the individual cells in the body. And as you're aware, there's trillions of cells in our bodies. And the pages in those books are these genes within each cell. And obviously, if it's there are different cells in the body. If it's a breast area, then there's breast cell, there's lung cell, different cells in the body. And these cells should be in the right place in order for them to be able to do their jobs properly. Then the pages in the books are the genes within the cell. And within these genes, the texts are the text on the pages. So the DNA sequences that make up each gene are the texts. So when we say DNA sequence, that's the part of the body that we can usually say that we can read. So if that sequence is actually altered, then the body won't be able to read, and it won't be able to produce the right proteins and the right functions for those genes, and that will affect the functioning of the body, and also they can result to illnesses. And that's when we say that there might be some genetic mutations, there might be genetic alterations or changes. Now, I've mentioned that there are trillions of cells in our body, and usually we have those changes in the cells. We have those different types of mutations. But even if there are some damages, repair, or changes or mutations in those cells, sometimes they don't really result to anything. They're just there. The body deals with it. They don't influence the functioning of the body. And sometimes the body has a way of repairing these cells as well. Now, just to expand this further, so when I talk about the DNA sequencing, you can see here on the top, let's just assume that this is the original sequence, the correct sequencing. So you can see the letters there. Now, if we're reading a book and the sequencing of the letters, then we'll be able to read the words, and therefore we'll be able to understand that. Now, there are different scenarios or instances wherein some of those letters within that sequence are deleted. So you can see that on the second line here. Can you see my arrow?
Mm-hmm.
Yep. So you can see here that one is deleted. So like any other word, if one of the letters are deleted or a few letters, then that will not make sense. And that's when it could cause, or it could tell the body to produce a protein or not produce a protein, or when it produces a specific protein, then it's not as what it should be, at what level it should be. And that can cause, and that could lead to illness, or that could lead to a deformity, for example. In some cases, from the original sequence on the top, there might be some insertions of letters. So that there's an additional C here, as you can see. Now, If that happens again, the word won't make sense, and that can result to a different protein, to a different word altogether. Then that will influence the production of some of the proteins, and that could cause illnesses or a specific condition or deformity. Now, when we talk about genetics, genetics is actually the study of heredity. So this, when we talk about genetics, it's about illnesses or conditions that are passed on within families from generation to generation. Now, there are different types of heredity, and how we do that is to understand the patterns of heredity. We usually draw a family pedigree chart. So maybe some of you might have encountered this, wherein the history of cancer, for example, is taken from the patient, and they will ask, the geneticists will ask if their siblings had cancer, or their parents, the siblings of their parents, their grandparents on two sides, and seeing the patterns of inherited disease. Now, not all diseases will have 100% inheritance. Some will just be about 50%. So there's a 50% chance of inheriting the disease, or a 25% chance of inheriting the disease. So really, when we talk about genetics, it's about the study of the function and composition of a single gene, a gene that is usually something that we already know that may cause or may increase someone's risk of developing an illness. So that's genetics. Now, when we use the word genomics, this is more about the complete genetic information of a specific organism. All living organisms will have a genome, and as based on my analogy I've mentioned earlier, it's about the complete library collection. And our understanding of the human genome was really from a big project that was undertaken a few years ago now, where it's called the 100,000 Genomes Project, that you might have already heard previously. And what they've done is that they sequence, or they read 100,000 genomes from about 85,000 patients who either have different types of illnesses, or different types of diseases. So this is really groundbreaking for us to understand more about the human genome and understand the sequencing of genes, the reasons why some genes are perhaps altered, but they don't cause any illness, although some might have some mutations in them and they might cause some illnesses. So that was really groundbreaking for this, and it was actually a springboard of many of the developments on genomic medicine that we have at the moment. So when I talk about genomic medicine, it's about using genomics or genomic testing in order for us to understand how we can treat an illness, or not only treating, but there's a whole range of benefits that we can get through genomics testing. So here you can see, this is from the NHS England, and you can see here that genomic medicine is being used in different aspects of healthcare. So here, from early diagnosis, so there are tests wherein we are able to identify illnesses or diseases at a really early stage. And as we're all, the earlier we diagnose an illness, the better the outcomes are usually. Then we are also able to have more precise diagnosis. So instead of saying someone has colon cancer, then we may be able to describe it better, like at the genome level. So maybe some of you might have heard of tests like, what is the KRAS? Is there a KRAS mutation or an NRAS mutation? So these are language that are being used to understand the nature of that specific colon cancer at a molecular level. So we are being more precise in our diagnosis. And as a result of that, we are able to offer more effective treatments, because unlike before, that everything that we can offer sometimes when we're talking about chemotherapies are the cytotoxic chemotherapies, meaning they are harmful not only to the cancer cells, but also they can also cause side effects to the normal cells. Now, if we are more precise, we understand what's within these tumor samples, for example, at a molecular level, we are able to target specifically what's wrong with the cancer cells, and hopefully not affecting our normal cells that much. Or if there's any side effects, then there might be fewer adverse reactions or side effects. And that explains this next piece of the pie here. It's about having fewer adverse reactions, whether we're giving the right treatment, the better treatment, or also for us to understand as well, because some individuals might be more predisposed or may have a greater risk of developing severe side effects. By understanding the precise diagnosis, we are also able to offer eligibility for clinical trials, and also there are elements of preventing. And I'm going to show you some example of how genomics can prevent some severe side effects and also cancers. Now, the impact of genomics on clinical services is not only in oncology or in cancer, but also in a wide range of different illnesses across our clinical services. So there's a lot of action going on in diabetes, for example, in cardiology or heart conditions, in lung conditions. So we are using genomics to understand the dynamics of the illnesses, to understand the individual. That's why we call it precision medicine, is understanding these illnesses at a molecular level is specific for that individual in order for us to choose the right fit for their specific diagnosis. So it is really exciting, and there's a lot of promise of genomic medicine in terms of all the benefits that I've shown you earlier. So when we focus on cancer and genes, we know that cancer is a genetic disease. So there is a specific change within the gene, and that's the reason why there is proliferation, or there is an increased uncontrolled behavior of the cells that is causing the cancer, that's causing that tumor or growth or extra growth than normal. And this is caused by, as I've mentioned earlier, changes in the genes. So most cancers results from changes or mutations in a single cell over a person's lifetime. So, for example, we know that there are certain risks that increase certain lifestyle practices, for example, that can increase someone's risk of developing cancer. So, for example, smoking, we know that that is directly associated with lung cancer. Now, there's also some diet, like unhealthy diet, understanding about environment and their impact on the cell and how it can cause mutations. Radiation is one, ultraviolet rays. That's why we advise putting some sun cream to protect the skin from mutations. So most of cancers are actually changes in or mutations in the cell during a person's lifetime. Only about 5 to 10% of cancers are linked to inherited genes. And usually this is something that worries a lot of people. I was one of them. My grandmother had cancer, and I always thought I will have cancer. But if we're going to look at these statistics, it's only about 5 to 10% of cancers that are linked to inherited genes. And here on this pie, you will see all the different understanding of causes of cancer, the carcinogens. And it shows you that only about 5 to 10% are family history or resulting from genetics. So here you can see tobacco, alcohol, being overweight, lack of physical activity, certain diets can predispose someone to developing cancer, and so forth. So you can see that on that right-hand side. Now, when we're talking about genomic testing in cancer, you might ask, so what can we test and what we can't test? And can we just test everything so that we will find out everything before they even develop? Now, all of those tests that are known at the moment are on the National Genomic Test Directory. So this directory is available online. It's very technical in terms of their of the wording, but what it gives us is an eligibility criteria on who can be tested for a specific test. What are the parameters of it? What types of tests those are, and what specific genes they're looking at when they do that specific test. And for some of you who might be thinking, can we just test for everything? What we have in this test directory are genomic tests where we can action the results. We can't just test every cell, every gene when we can't really action, because it's just testing for the sake of testing. But if we can't action them, then there's no point of doing that. So when I talk about actions of the results, I'm talking about, can we do a more regular cancer screening or a more rigorous cancer screening? Do we need to check the family as well if we're talking about an inherited illness? Or if we have a genomic test that might show a specific gene that is actionable, then maybe we can prescribe some precision medicine or targeted treatments if they are available. And as I've mentioned earlier, a lot of these medications are evolving. There's a lot of new drugs every now and then. So even for us, we have to get really very quickly in understanding the new drugs that are coming out, because these drugs are I mean, I think with from the Human Genomes Project to the understanding of how cancers behave, the genes that are involved, then there are more understanding of what drugs can target what. So there's always an evolution of these treatments. And usually you will hear NICE releasing some information about new drugs, about new indications for several drugs based on some clinical trials and studies. Now, just going back to genetics, and I've mentioned that when we talk about genetics, we're talking about testing for family history of cancer. So if someone is invited to have a genetic test, the result could be three things. One is positive, meaning that they have the either the mutation of the gene or the lack of that gene. It could be negative, or it could be a variant of unknown significance. Negative is that it's normal. Variant of unknown significance is sometimes there is a change. However, at the moment, we don't know what this change is. It could be that it is negative, that it's insignificant, or maybe in the future when we have other means of understanding these changes, then it might give us a different interpretation. If someone is positive for a genetic test, or say, for example, they're positive for BRCA, it is a predisposition. It is not a cancer diagnosis, meaning there is an increased risk of developing cancer, but it is not a cancer diagnosis. So I'll just give you an example of a genetic test. Here in Berkshire, we're doing Lynch syndrome mainstreaming. So you might have heard of Lynch syndrome. So Lynch syndrome is caused by a genetic change to the genes or genes that are involved in stopping some cancers from developing. And we call these mismatch repair genes. Now, usually if there is damaged DNA, so I'll just point on this bottom line here. When there's damaged DNA, we have our mismatch repair genes, the MMR repair genes that will correct that error. However, if someone has Lynch syndrome, they have defective MMR repair genes or deficiency of these repair genes. So if there is a damage, then there is no repair genes, and therefore that DNA damage is not repaired. The cells can grow out of control, and then that could develop into tumors. Now, we know that Lynch syndrome increases a person's predisposition to colorectal cancer, to developing colorectal cancer, and also endometrial or womb cancer, and all other cancers, but more like less significant, such as brain cancers, pancreatic, bile, kidney. So there is a testing that we do for Lynch syndrome. And what we do is we invite all newly diagnosed patients with colorectal and endometrial tumors to be tested by this. When I say all, what we do is once they are newly diagnosed, the tumor sample from the biopsy is automatically sent for initial testing. Even the patient might not even know this, but we just send it straight away for testing. Now, if that tumor test comes back and it is suggestive of Lynch, for example, it shows that there might be some unstable mechanisms that are seen there, or structures, then we invite the patient for a blood test. And then the patient's age and family history is also considered, because those who are less than 40, we invite them to be tested for any cancer within the family, and also especially colorectal cancer, and also a strong family history is included to see if there might be a suggestion that this might be there's a pattern within the family. Now, you might ask, why can't we test the Lynch gene using the biopsy sample alone? Why do we have to do a blood test? Now, if the gene is only, or like the deficiency is only present in the tumor, then that's only the tumor. But when something is hereditary or familial, then that Lynch gene will be present in all the cells of the body. That's why it will be recognized and tested within the blood. So that will show in the blood, not only in the tumor. So what happens when we invite our patients to the Lynch clinic? We do a discussion, because there will be an implication to them and also to their families, especially if it's positive. We take a consent, and then a blood test, and also take a family history questionnaire. You might ask, can a patient refuse the test? The answer is yes, they can refuse the test. And once the result comes back, then the patient owns that information. It's up to them whether they want to share it with their family members, especially if it's positive. It's actually their own decision. That result is theirs. Now, if that's positive, as I've mentioned earlier, if we test something, there should be actions that come with it. So they could be, if it's positive, they could be invited for more regular screening compared to the general population. They might be offered risk-reducing surgery, like colectomy or a similar screening. When they do the bowel screening, they might automatically remove everything that they've seen. Aspirin prescription also. There's a study that showed that aspirin for Lynch, it actually decreases the predisposition of a person from developing colon cancer by about 30%. We will offer lifestyle advice and offer family testing. We give them a letter that they may give to their like loved ones to say that that there's someone in the family that has been tested for Lynch syndrome, so that they can be tested themselves as well. There's also a consent for whether they want to be part of a future research for future developments. So, for example, keeping their genetic material so that if there's any new drug that they might want to research on eventually, then they could be consented for that. And then also to offer psychological support. These are links to Lynch syndrome if you want to know more about it, on the Bowel Cancer Lynch Syndrome UK website and Lynch Syndrome Eve appeal. So in terms of BRCA, so BRCA1 and BRCA2 genes are linked with breast, ovarian, and prostate cancer. And if you can remember from before, it's the Angelina effect. When Angelina Jolie started talking about BRCA1 and BRCA2 and had a double mastectomy, then that's when we heard more about these genes. So in terms of testing for BRCA1 and BRCA2, it's similar. It's a blood test is taken, and the results, if it's positive, then it's similar to what the slide I've shown you earlier. So there might be targeted treatment that's available for our patient. Therefore, we can offer a more precise treatment. They maybe offer a more regular screening, surgery that could reduce their risk of developing, lifestyle advice and family testing, and so forth. So those two are examples of the genetic tests. Some of the questions that we hear is about eligibility of testing. So who is eligible for these different genetic tests? As I've shown you earlier about the National Genomic Test Directory. So there's a strict criteria of that. If we're talking about a strong family history, there is a scoring system that we use. So the geneticist will use that, and also the GP. So say, for example, someone goes to their GP and is concerned about their family history, then there's a scoring criteria that will fit into that eligibility criteria for testing. So where can you get the testing done? As if the individual is a patient here in hospital, then we will be able to offer the testing here. However, if this is a member of the public, say a relative of someone diagnosed with Lynch syndrome, then they can go to their GP to have the testing done. Where can my family get more information if I am tested positive for an inherited gene? As I've mentioned earlier, they can go to their GPs. The other one that concerns many people is about insurance. So there is an agreement with the Association of British Insurers that they cannot ask an individual if they have been tested for any genetic disease or illness. So that information is owned by that individual, and they're not they can keep it to themselves unless there's an actual diagnosis. Then they might want to divulge that to their insurers. So the other question is, what will happen to my DNA sample? These are stored in NHS labs, and they are kept there for future testing. However, those future testing will not be done without the consent of the individual. In some cases, they are being used to test some of the machines that are being used, and they are being used anonymously. And this is just to ensure that the testing are as rigorous and the machines are working properly. Some individuals ask, we have many cancers in the family. Does this mean I have the gene? The answer is not always yes. It's actually mostly no. In many cases, only 5 to 10% of cancers are caused by an inherited gene. And it could be that the many cancers that existed in the family might be due to some mutation because of lifestyle, because of different carcinogens or cancer-causing drugs or maybe cancer-causing chemicals that they have encountered, or radiation, for example. So no, it's not always the case. And there's as mentioned earlier, scoring that we use to refer someone for a genetic test. So not everyone will be referred for a genetic test. So those are the genetic testing, but also we have some genomic testing for that can inform cancer treatments. So for example, this is a bit difficult to explain because the animation had come off. For example, some of the cancer drug treatments target specific molecular processes within the cell, and these are things that I don't even see, and it's a theory, but they work. So for example, for this one, I won't bore you with all the different words that are really complex here. Some drugs inhibit a protein called PARP. So if we give a PARP inhibitor, because we know that if we inhibit that, then that will kill the cancer cell, then that's the drug that we're going to use. But we need to do a test first to be able to offer this treatment. So if you've heard of these drugs, olaparib, talazoparib, they inhibit the PARP protein, so that will not repair the damage, and it will cause a death of the cancer cells. So that is an example of a precision medicine. Sometimes we also have tests that will identify if someone will develop more severe side effects. So for example, for patients who are prescribed to receive chemo, such as 5-FU or capecitabine, we test for an enzyme called DPD, a gene. We test for DPYD gene. And if there is a mutation, then that gene is not allowing the body to produce enzyme, the DPD enzyme. Now, without these enzymes, someone is really more predisposed to having more severe toxicities due to the drugs that we are giving them. So if there is an alteration of that gene, then they may be able to reduce the dose to ensure that that individual doesn't suffer from more severe side effects, or maybe explore other options for that individual if the gene is not producing any enzyme. So that's an example of how genomics can help in reducing the side effects. So other developments that you might have heard on the news is about the use of liquid biopsy. So liquid biopsy, as you may have maybe extrapolated from the term itself, it's the use of blood test to understand if there is a specific tumor within the body. So instead of bringing someone again to theaters to have a biopsy test, we take a blood test instead. So this is the explanation of this is that for some tumors, there may be secreting some of these tumor cells in the blood, and therefore we may be able to see that and understand, and will be able to offer treatment for those. At the moment, the liquid biopsy technique is only being offered to some breast cancer testing for a specific drug like elacestrant, but also for some lung cancer drug treatments. So this is the future, and this is hopefully we can use this more in other cancer tumors, because it actually is good for the patient, because they don't have to go back to theaters. It's cost effective because we don't have to use the resources in theaters, but also it is quicker because once we have the blood test, then we will be able to understand the dynamics of an individual's diagnosis. So what's happening in RBH? We are continuing to develop pathways for genetic testing, but also ensuring that if there are genomic tests for specific treatments, we are working closely with our regional genomic center and geneticists for us to be able to develop more our staff members to understand genomics more, and help also in explaining these complex, really complex terminologies and technology and tests to our patients. And we are hoping that our patients and members of the public also will be able to help us in making it more understandable, because sometimes if we know some of the language, it's difficult for us to find the words, and you might have already noticed that it's difficult to find the words if we're so used to using the medical jargon. So I would welcome anyone who would like to help us in developing some of the patient information leaflets, for example, in order to communicate this more to patients and members of the public. So that is a quick overview of genomics and genetics and some examples. If you have questions, this is my email address, but I'm also happy to answer your questions.